Wonderful. Such a pleasure to be here. Thank you, Moritz, and thank you, Laura. Fun to be here, see so many friends, and hear about all the exciting research updates. The field has really come a long way over the last 5 years. So I am a pediatric epileptologist, so I am largely clinical, so I see some GNAO1 patients, but also a lot of other rare complex epilepsies. But today I'm going to be talking a little bit about the epilepsy in GNAO1, which we are all relatively familiar with. The movement disorder is a little more prominent than epilepsy, but it does, about half of patients will have at least one seizure. Many, of course, have many more seizures. And I think, the movement disorder part of GNAO1 understandably gets a lot of attention. It really is, striking and unique. I think the epilepsy has certainly the same degree of challenges, but it is not necessarily as distinct as compared to other rare diseases. So I think some families might feel that the epilepsy often is not talked about quite as often, but we do know now over time how what the epilepsy looks like. And so the most common type of epilepsy is the infantile onset DEE, developmental and epileptic encephalopathy, which I'll talk about that term a little bit more. We also have many children and adults that have an early onset movement disorder, plus or minus the epilepsy, and that can be quite variable, and then those that do not have epilepsy. So the developmental and epileptic encephalopathy, DEE, is a concept that's been around now for a while, but is quite relevant in this community. And the idea here is that the epileptic activity, and this may include seizures, but also the very, very frequent spikes that we see on EEG, that both of those contribute directly to developmental impairment. We call it ictal and interictal effects. And the idea here is that this affects the developmental trajectory of a child's experience. That contrasts to a developmental encephalopathy, which is a term we use in the epilepsy literature. And the idea here is that they do have epilepsy, or they can have epilepsy, but that each seizure is not necessarily affecting that child's developmental trajectory. And so they may still have they still do have abnormal development, but that's more due to the underlying genetic disorder. And the reality is, in many patients with epilepsy, it's a combination of both. I think this is helpful. Just this year, Ingrid Scheffer and others put together a operational definition of DEE, really for the purpose of clinical trials, so that we can try to be a little bit more homogeneous about it. And it needs to contain these three pieces: frequent seizures and or EEG showing frequent epileptiform discharges, the history of developmental slowing or regression, and that there's an underlying etiology that also has a developmental impairment. So what's been published so far in GNAO1, I think over the last 10 years, really, we understand it a lot better. There are now 16 different variants that have been described as having at least seizures, and therefore epilepsy. 149 unique cases that I could find. 53% of all those published have a reported epilepsy or seizure. And on this chart, what I have is when these seizures or symptoms started. So what you can see is that most people describe or report the symptom onset. Any symptom could be seizure, could be feeding issues, could be movement disorder before the seizures or movement disorder come on. So what you see in the purple is that within the first month of life, and these are just raw numbers reported in the literature, that many of them, you see lots of purple over towards the 1 month, 3 months, that a lot of people present early. Those with seizures, nearly half of them will present with seizures within, if they're going to develop seizures, it's going to be within the first month, and certainly within the first 3 months. Some do develop seizures later. Whereas on the flip side, I'm sure what a lot of families see is the movement disorder often comes later. So now these are looking just at patients with seizures, but the movement disorder often lags after the onset of the seizure. So looking at the different phenotypes, The most commonly reported phenotype is the DEE, and here I'm lumping all of the developmental and epileptic encephalopathies together, and that's about 66% of what's reported. And going through and looking at some of these reports, and I've been trying to figure out what kind of DEE really is it. Sometimes I can't tell. Sometimes it's a clearly defined EIDEE, which I'll talk about a little bit more, sometimes infantile spasm syndrome. Often the EIDEE then becomes the infantile spasm syndrome, which technically is supposed to have epileptic spasms plus hypsarrhythmia, as well as developmental stagnation. And so they can move from one DEE to a different type of DEE. There are some in the literature described as just as having focal epilepsy, 11%. Generalized epilepsy is less common in this disorder. And when I say generalized epilepsy, I'm really thinking about the true genetic generalized epilepsy, which is not as prominent in this disorder. Sometimes it's just difficult to tell from the literature what type of syndrome it is. But I think one thing to highlight is that just in the literature, and I've seen this in my patients as well, that there are some patients that are well controlled or have a self-limited epilepsy. And in the literature, it's reported as 21%. And I'll talk about a case of that in a moment. So these are the two kind of buckets that I put this in, is either the EIDEE or the non-DEE. Typically, and as required for a true EIDEE, they must have seizure onset before 3 months of age, which I told you that is most common. They have very specific EEG or very abnormal EEG criteria, so things like burst suppression, hypsarrhythmia. It can change from one to the other over time, multifocal spike wave discharges, generalized discharges, and background slowing or abnormalities, lack of awake and sleep, normal awake and sleep features. Technically, for an EIDEE, you must have tonic seizures or myoclonic seizures. And I think that that's probably overlooked a lot in this disorder, is that many patients, some do have those spasms, tonic seizures and myoclonic seizures. But if you only have focal seizures, technically, you might not meet criteria as is defined by the ILAE for EIDEE. So thinking carefully about that is, I think, important. For EIDEE, they all have global developmental delay, may or may not have a movement disorder. In the non-DEE bucket, these are patients that typically present with seizures a bit later, 3 years or later. They can have a normal EEG. It is also quite common that they have an abnormal EEG, and this can have focal or generalized discharges, background abnormalities, lack of awake or sleep features, like we heard about yesterday, that the EEGs do tend to be quite abnormal. Seizure types can vary. These are not your patients that are going to have tonic seizures, myoclonic seizures. These are generalized tonic-clonic or bilateral tonic-clonic, as we call them now, focal seizures, and can even be typical absence seizures. Development may be normal or delayed, and that these patients do typically have movement disorders. So I'm going to talk about a case to illustrate a concept that I've been struggling with a little bit. So this is a neonate that was born full term, no issues during pregnancy. 5 minutes after birth, the baby had an event concerning for a seizure, witnessed by the nurses, was given a dose of phenobarbital, which is a typical medicine we use in babies with seizures. And then the 1 hour EEG after that did not show any seizures, so the child was discharged. A week later, at a gestational age of 41 and 2, this child had multiple episodes of cyanosis during feeding and was admitted to the hospital. And this is what her EEG looked like. This is quite abnormal EEG for a baby. And what we saw was excessive discontinuity for age, abundant multifocal spike wave discharges, sharp waves, and interhemispheric asynchrony, which is quite prominent here and abnormal for a baby of this age. But most interestingly was that she had numerous left temporal seizures. So this is an example. I know most people here are not reading EEGs, but this is a quite evident example of a left temporal EEG, or left temporal seizure here up on the top, that evolves over time. And in total, she had 16 left temporal seizures before they were able to be controlled with medication. And although that sounds like a lot of seizures, it's actually not a whole lot for babies tend to have lots and lots of seizures. And these seizures were very well controlled with phenobarbital. She was discharged, and Well, as I understand it, the genetics did not come back, but then about at the time where her diagnosis of GNAO1 came back, she was also weaned off of phenobarbital. It's not a medicine we leave kids on long term, and so the clinician and the family had decided, let's take her off and see how she does. And she's actually been seizure-free since that time, and now is 6 years of age. She does have global developmental delay and is nonverbal, although I've learned I should be saying non-speaking, and is working to use an eye gaze device, but is starting to develop dystonia. So I think this is a good example of how our cross-sectional nature of case reports don't tell the full story of this patient. This is just looking at the EEG. This is what her EEG looked like last year, and this is the same one, just with the sensitivity down so we can see a little bit better. This is a child awake. This is an extremely abnormal EEG. There's too much, as we're talking about yesterday, too much delta, not very much alpha. There's spike wave discharges showing risk for seizure. But she is not having seizures. So her EEG has changed over time, and I'm sure families of children with or without epilepsy have noticed this, and really, the summary of these changes over time is continuing to show a risk of seizures and that there's encephalopathy. And so there's a lot of technical stuff in the EEG reports, but that's kind of the summary of what we see with a lot of these patients. And so for this patient, is this a DEE? And thinking about our definition, yes, there is developmental slowing and regression. The underlying etiology affects the developmental trajectory, but there's not frequent seizures or EEGs showing frequent epileptiform discharges. So this child does not meet criteria for DEE, despite the fact that she had quite a few seizures just in one day in the neonatal period. So comparing, this is the variant that she had, the D273Y, comparing to other published reports, kind of a similar story of early onset seizures in a child that then becomes seizure-free. So I think this patient's, quote, twin with EIDEE that becomes seizure-free is one of those, kind of good stories, well-controlled or good outcome, shows some similarity at this specific residue, but highlights perhaps the challenges in describing this in the literature. You can see all the two very similar variants on the bottom, also reported out as a DEE, but we don't quite know exactly, there's not a lot more details to figure out if they still meet criteria for a DEE. So why do we care about this? So the idea here is that GNAO1 is going to cause this developmental encephalopathy as shown in the orange here, and that if you have a DEE, that their clinicians are going to be telling you, okay, yes, the seizures are affecting the ongoing development, but sometimes that may not be the case, that it really is, even if you have seizures, it's more of a developmental encephalopathy. So I think, DEE is still by far the most common phenotype. Often it is the early infantile DEE, which is kind of one of the main OMIM terms here, right? And that it often is medically refractory and very difficult to control. But there's also patients with a developmental encephalopathy plus epilepsy that can have seizures in infancy that can be self-limited. And there are also milder cases where may only have a single seizure or well controlled on medication. Briefly about treatment, because I know that's what a lot of families are interested in. We still don't have a single best anti-seizure medication. We don't call them anti-epileptics anymore because they are not anti-epilepsy, they're anti-seizure. And no definite disease-modifying treatment for epilepsy at this point. And in a simple way, your child is likely to either be easily controlled on a single medication or quite medically resistant and on tried and failed multiple medications. Generally, we as epileptologists and neurologists target treatments towards an epilepsy syndrome if one is identified. So for example, if a child has epileptic spasms, there are certain first-line therapies that are important to try first. And then, just as I was mentioning, many patients do end up trying and failing many medications. So it's important to balance, what is each medication doing, not piling on more and more medications, and understanding that more medicines are likely to have side effects and worsen drooling, affect feeding, all of that. So it's certainly a challenge. Just to highlight a couple of things, this is now a couple of years old and was mentioned yesterday as well, but perampanel or Fycompa, as we call it in the US, is a brand name. This is approved for focal epilepsy in the US for age 12 and above. The study reported that 4 patients with GNAO1 became seizure-free. It is quite interesting. I think as precision therapy is not quite the right word. All the basic scientists can help me if I'm wrong, but I don't think that AMPA receptors are necessarily a high target here. But perhaps trying a medication with a different mechanism of action led to this great outcome. But I know that there are a lot of families that are trying this, and certainly something to consider. And of course, we all heard about the Zinc trial with Moritz and Dr. Katetnayev. And they did show in the one that they've reported that the seizures reduced as well as other improvements. So we're hopeful that the results of that will show improvement in seizures as well. So just briefly, I also do our ketogenic diet clinic, and so I've been interested in that effect on GNAO1 patients. There are 11 cases reported in the literature. All of them are highly medically refractory, and that's been my experience as well. In my case series, no patient became seizure-free on the ketogenic diet, but the benefit there is that it may not have the sedating side effects that some of our anti-seizure medicines will have. So I have patients that still want to be on it and like to be on it for that reason, even if it's not leading to seizure freedom. I think just for parents that don't know about the ketogenic diet, this is not just doing some extra fat in your diet. It's a highly supervised medical diet that requires a lot of laboratory monitoring and can be unsafe if not done well. So it requires a ketogenic dietitian as well as a physician specialist in it. Other things of interest is neuromodulation, which is kind of a hot topic these days in the epilepsy field. This includes vagal nerve stimulators and deep brain stimulators. Of course, you all know about deep brain stimulators because it's used for the movement disorder side, but also increasingly used for epilepsy. It's approved in the US for focal epilepsy, but there's a lot of using it off-label in children in Lennox-Gastaut syndrome. So I'm always interested in asking patients that if they have epilepsy, if they're and a movement disorder, if their seizures improved. I think the answer to that is not yet clear. I'm still looking at patients with and without epilepsy to try to understand how things are changing. So if anybody is interested, it's English language only, unfortunately, but they can email me if they're interested. And so in summary, I think the main phenotypes we have are the DEE versus a developmental encephalopathy plus epilepsy, that there's unfortunately still no single best anti-seizure medication. Our ultimate goal is going to be true disease modification of the epilepsy, but of course also of the developmental encephalopathy. So thank you to all the families and the parent organizations here, to the Bow Foundation, and to my team back in the US.